Good morning, good afternoon, good evening. My name is Marvin Zick, coming to you live from Berlin, and we are super excited to have you here for this 5th World Sepsis Congress Satellite Session on the Metabolism of Sepsis. Welcome from all over the world to this Satellite Session for the 5th World Sepsis Congress, which, as you of course know, is just 6 short weeks away before we will go live on April 8th and 9th, 2025, with an amazing program. We have 15 sessions. We have close to 100 speakers, moderators, thought leaders, experts from all over the world. And to whet your appetite a bit, today we are hosting this satellite session on the metabolism of sepsis. It simply didn't fit into the program anymore. April 8th and 9th is packed, and we can't wait for these 6 weeks to be over and to welcome you for the 5th World Sepsis Congress, which has a long history at the Global Sepsis Alliance. It was founded back in 2017 as the first World Sepsis Congress, and ever since then we have done one almost every year. There was one exception, but who's counting? And now, again, in just a couple of weeks, we will be welcoming thought leaders, clinicians, scientists, researchers, policymakers from all over the world to this amazing event. And today we are kicking off the waiting period with this satellite session on the metabolism of sepsis. And now, without further ado, let me introduce my amazing co-organizers, Marcella and Maxim. Marcella, over to you.
Good morning and good afternoon to everybody who is online. First of all, let me thank to Global Sepsis Alliance, namely to Marvin and Mariam, who helped us to build this lovely event. And this session, it's built and it's organized by our consortium Beat Sepsis together with European Immunometabolism Network and with Global Sepsis Alliance. And together today I'm here with Maxim Nosenko from Trinity College London, and we will co-share this event, which will be combination of early career researchers together with renewed scientists on the field, which are placed all over the world. And it will show as a combination of the different expertises with the aim to provide you comprehensive insight to the immunometabolism of sepsis.
Thanks, Marcella. And I would also like to join and say that I'm really pleased to co-organize this session with you guys. And just want to point out that, well, obviously we're for decades know a lot about metabolism of like metabolic changes that happening within the sepsis, but we're still yet to discover why is it happening and what it means in terms of the disease outcome, right? So we really wanted to compile this session of 6 speakers and the discussion after that to hopefully get more insights about what it means to have different metabolism for the sepsis patients and hopefully find novel therapeutic targets. So looking forward to the talks and to the event. And back to you, Marvin.
Thank you both. I'm super excited to be doing this with the two of you. And one more person whom without nothing of this would be possible is our CEO, Dr. Mariam Jashi, from Georgia, joined the GSA about 1.5 years ago, has catapulted us into new stratospheres. And she is also one of the program chairs for the upcoming 5th World Sepsis Congress. So who better to say a couple of opening remarks than Dr. Mariam Jashi? Mariam, over to you.
Thank you, Marvin, and it's a true honor and delight to co-organize this session as the CEO of the Global Sepsis Alliance in partnership with Beat Sepsis, the European Immunometabolism Network, International Clinical Research Centre, and the Trinity College Dublin. We are delighted to provide the opportunity to share the latest cutting-edge evidence and knowledge in the sepsis metabolism that is critically important in paving way to the research and development for the new diagnostics and therapies. And on behalf of the Global Sepsis Alliance, I would like to highlight that our vision is not only to medically transform the global sepsis response, but to politically transform the vision for the 2030 global agenda for sepsis, the new multi-year global strategy, as we intend and invest efforts for positioning sepsis on the high-level political agenda. It is still difficult to explain how the global health threat affecting almost 50 million children and adults every year is not the main theme of discussions on the global health or political platforms, and especially in view of the latest remarkable progress in terms of AMR advocacy. The 5 million AMR-related deaths are only part of the 13 million sepsis-related deaths, and yet we fail to position sepsis in the mainstream of ongoing excellent discourse around antimicrobial resistance. We hope that through reinvigorated partnership, reinvigorated political action, and the 2030 Global Agenda for Sepsis that we launched at the German Parliament in partnership with the Virchow Foundation and Unite Parliamentarians Network, we would be able to strategically position sepsis on the global health and political discourse and ensure that we have substantially increased investments, both political and financial, in sepsis science, sepsis research and development, and hence we welcome this opportunity to discuss this critically important sepsis metabolism theme with our esteemed and distinguished speakers for this session. Thank you, and I hope that Niranjan Tex-Kisun, the president of the Global Sepsis Alliance, would be also able to join us in the due course. Thank you.
Thank you so much, Mariam. And now, without further ado, let me hand it over to you, Marcella, to introduce our first speaker.
Thank you so much. So it's my great pleasure to introduce you first speaker of this event, and it's Sarah Huen. It's physician and scientist coming to us from University of Texas and from Department of Internal Medicine and Pharmacology. She did very excited postdoc within the Ruslan Medzitov lab, and currently she's exploring metabolic defense pathways that promote organismal tissue protection and survival during inflammation and tissue injury. Sarah, stage is yours.
Okay, thank you so much for that kind introduction and for the opportunity to speak in this session on metabolism and sepsis. So today I'll discuss the impact of metabolism on surviving sepsis. So as this audience knows, the most recent clinical consensus defines sepsis as life-threatening organ dysfunction owing to dysregulated host response to an infection. And we know that sepsis can cause severe multi-organ dysfunction. And despite the availability of broad-spectrum antibiotics and life-supporting technologies, even though sepsis accounts for only about 10% of hospitalizations, it accounts for 50% of in-hospital mortality. And it remains the most expensive hospital diagnosis. And although there are many metabolic derangements associated with sepsis, including metabolic changes associated with poor appetite, hyperlipidemia, dysglycemia, and proteolysis, whether they're truly dysregulated and pathologic is unclear. So as clinicians, we like to normalize clinical parameters. So when we see metabolic derangements in sepsis, we want to correct them. But the question is, does this improve outcomes? And we've tried, for example, insulin to correct hyperglycemia, and that caused more mortality. We tried growth hormone to prevent proteolysis, and this also increased mortality. And multiple nutritional interventions have been tried, including high versus low calorie targets, and this didn't affect outcomes, or giving high protein feeds to minimize negative nitrogen balance. And this also didn't have any effect on outcomes. So why so many negative studies? Well, one problem is that they estimated energy requirements, not measured. And so it's unclear if we can accurately calculate caloric needs. Also, these estimates don't account for changes in metabolism during the course of illness. The feeds aren't standardized and they target total calories. So it's really unclear if the type of calorie matters. And finally, the cohorts are very heterogeneous. Oftentimes, trauma patients, burn patients, post-surgical patients, as well as septic patients are all mixed together. And is it possible that different types of critically ill patients need to be fed differently? So to study this experimentally, we asked, what is the purpose of anorexia in acute illness? And anorexia is a component of sickness behavior that's very highly conserved. And it still remains a question of whether it's an adaptive and protective response in conserving or reorganizing energy expenditure, or it's completely maladaptive in the face of what we presume to be a hypercatabolic state. And so to test this, we use common laboratory mouse models of infection. So we use Listeria for bacterial infection and influenza for viral infection, and we measure their food intake. Both infections suppress food intake. And so then we asked, okay, well, what happens if we feed the mice during this anorectic period? How would that change their outcome? So we fed mice a common ICU tube feed, which was Abbott Promote, which had very similar macronutrient composition compared to standard rodent chow. In Listeria infection, feeding the mice about 20% of their caloric intake dramatically increased mortality. However, we were surprised to see that the opposite effect in influenza infection, with the hypocaloric feeding improving survival. So which food component was responsible for this effect on mortality? So we found that glucose, but not protein or fat, increased mortality in listeria-infected mice, while glucose had a partial effect in rescuing influenza mortality. Instead, if we inhibited glucose utilization with 2-deoxyglucose, a glucose analog that cannot be metabolized, this reduced listeria-infected mice mortality, but uniformly killed the flu-infected mice. And this glucose metabolism effect was independent of pathogen load. And this effect can also be phenocopied using lipopolysaccharide or poly-IC to induce bacterial or viral inflammation without a live pathogen. So what are some implications of these metabolic adaptation pathways in the context of managing patients with sepsis? I think first we need to acknowledge that the purpose and regulation of metabolic changes during sepsis is really incompletely understood. Next, changes in metabolism may in fact be part of immune defense. So this suggests that host defense against infections consists of not only resistance, which is focused on pathogen clearance, but also on tolerance, in which physiologic responses are activated to limit tissue damage caused by infection and inflammation. So therefore, a lot of metabolic changes that occur in response to an infection may in fact be beneficial and part of tissue tolerance defense pathways. So then we have to consider the possibility that how we feed and medicate septic patients in order to try to normalize what we presume to be maladaptive metabolic changes could in fact be detrimental. And finally, the optimal nutritional management may differ depending on the type of infection. And I'm pretty sure this is going to be much more complex even within classes of pathogens. So there's a common critique that mouse studies of sepsis are not translatable to humans, reflecting so many negative studies that appear to work in mice but show no benefit in patients. So if we look back at our mouse data, if you feed mice with listeria infection, it increased mortality, while feeding decreased mortality in flu infection. If you mix these cohorts together, there's no difference in mortality outcome. And this is quite similar to what we see in clinical trials that mix a whole lot of different patients together. So my lab has been very interested in understanding why fasting metabolism appears to be protective in bacterial sepsis. So what is the mechanism by which glucose and fasting metabolism are incompatible in bacterial inflammation? If you looked at normal fasting metabolism, there's an induction of adipose lipolysis. These lipids are then released to the periphery and they activate fatty acid oxidation. In response to these lipids, the liver will produce fibroblast growth factor 21, which is a starvation adaptation hormone. The liver will also use these lipids to make ketones that can be used as an alternate fuel and can have other functions such as antioxidant effects. So bacterial sepsis or even endotoxemia also induces these components of fasting metabolism. And glucose supplementation will suppress, for example, free fatty acids. It'll also suppress the production of FGF21 and ketone bodies such as beta hydroxybutyrate. And this is associated with increased mortality. So we found that hepatic FGF21 during sepsis is protective. And unlike other FGF21 functions that map to the hypothalamus, FGF21 in sepsis activates neurons in the hindbrain that express its obligate co-receptor beta-klotho. And these neurons are in areas that participate in autonomic control, regulating cardiovascular function and body temperature. And this suggests the novel FGF21 site of infection. So returning to ketogenesis, we had hypothesized that another major negative effect of glucose supplementation was the suppression of ketones, which would provide an antioxidant effect. So using a liver knockout of the ketogenic enzyme, these mice do not develop ketosis. And surprisingly, they have no difference in LPS survival. And so ketones are apparently completely dispensable. But if you look more upstream, ketone production could just be a byproduct of a much more important upstream metabolic pathway, fatty acid oxidation. In fact, many preclinical studies examining the role of major regulators of fatty acid oxidation, such as PGC1 alpha and PPAR alpha, have shown that if you inhibit either of these regulators, it results in worse septic organ injury, while augmenting their activity limits septic organ damage. So if we return to fasting metabolism, glucose and subsequent insulin signaling will suppress fasting metabolism, in particular fat oxidation. And this is because biochemically and hormonally, as regulated by insulin, the provision of glucose will suppress fatty acid oxidation. So if we consider the current paradigm of glucose control in the ICU, when you looked at prior to the Nice sugar trial, the observational data was clear that hyperglycemia associated with increased mortality. So it was intuitive to hypothesize that using insulin to mitigate hyperglycemia would improve survival. But then after the Nice sugar trial, we saw that intensive glycemic control using insulin increased mortality, likely due to increased hypoglycemic events. But these patients were also exposed to significantly more of both insulin and glucose. So could the exposure of excess insulin and glucose also be harmful? So today we discuss the potential of current clinical interventions that are meant to correct these metabolic derangements to instead potentially suppress protective metabolic programs, leading to a decrease in host defense through decreased disease tolerance. One example is glucose supplementation to mitigate sickness-induced anorexia, and that results in suppression of fasting metabolic pathways, of which there is growing evidence that they may be protective. I'd like to thank my lab and collaborators and fundings for this work, and thank you for your attention, and I'm happy to take any questions.
So thank you very much, Sarah, for such a nice talk. I will have a look if we have any questions within the chat. But first of all, I will ask you, since there are some metabolic requirements between the glucose and fatty acid oxidation, do you think this kind of metabolic rewiring can serve as a, let's say, some diagnostic marker with some diagnostic potential to distinguish if the patient is in such a or specific state, that if it's going for example, for the better prognosis and it will develop better, or on the other hand, or vice versa, let's say?
Yeah, absolutely. I think the hope would be is that we could identify, I guess, biomarkers, or at least do some sort of testing to identify what can clearly identify what kind of metabolic state patients are in. I think right now, in terms of patient studies, there's a huge lack in understanding, especially throughout the course of sepsis, what patients are using for metabolic energy, right? And what their preferences are as well. And that we don't really have a good handle on. And for the most part, a lot of the studies, as I had mentioned, really only use the equations to estimate energy expenditure or fuel utilization. There's just not a lot of use of indirect calorimetry, unfortunately, which I think needs to be done.
Okay.
Probably, more routinely.
Okay, so we have here some question within the chat. So it's excellent talk, definitely food for throat. We are probably overfeeding some of our septic patients, in particular with early TPN. So probably the food, it's one of the critical points within the sepsis care. And there should be some question on YouTube. Did you check cytokine production or inflammatory cells phenotypes during these different conditions?
Yeah, so that's a great question. In the initial study where we had studied listeria and influenza, also with LPS and poly-IC models, we did look at a panel of cytokines, and we didn't really see a significant difference in the levels of cytokines. And also in terms of just different subpopulations of immune cells, there wasn't a significant difference. That being said, we had not phenotypically or functionally analyzed the different immune cell types to determine whether or not the glucose or the 2-deoxyglucose affected immune cell function.
Okay, thank you so much. I think that we will move to another speaker because of the time limitation of this session. So
Okay, well, thank you.
thank you so much. So it's my pleasure to invite and introduce for a second speaker of this session. It's Maxim Nosenko, who is currently Marie Curie postdoctoral fellow in Trinity College Dublin in Ireland, and in his former studies he was studying the cytokine biology and inflammation, and now he moved much more to the area of the immunometabolism, and he's focusing on metabolic requirements of immune cells. And Maxim is very active also within the European Immunometabolism Network, and as well as in young researchers of the European Federation of Immunological Societies. So Maxim, stage is yours.
Thank you very much, Marcella. It's a really big pleasure to share and like to hear the talks and share also this ongoing project that I'm working on. So this the project is focused on NK cells. So like if we speak about the bacterial infections, so most of the times a little bit overlooking the role of NK cells there, because we think that NK cells are more, let's say, antiviral response and anti-tumoral response. But this is actually not the case. So NK cells actually playing a big role in the fighting the bacterial infections as well. So they can directly recognize bacteria cells, or they can do it indirectly, just from the cytokines from other immune cells. And so what NK cells do, they do two major things that they usually do, right? So the first thing, they produce a lot of interferon gamma, especially early in the infection. And interferon gamma is a cytokine which is really essential for, say, stimulating or helping other immune cells to fight the infection. But at the same time, NK cells were shown to directly target bacterial cells, or, let's say, infected host cells with cytotoxicity, like, for example, by producing perforin. And so while both of those functions are actually quite helpful and aim to eliminate the pathogen, so they contribute to the resistance mechanism of the, let's say, organismal response, their excessive production might be also be quite damaging, and it can induce tissue damage. And also, let's say, excessive interferon gamma production might lead to more of the prolonged immunosuppression state, which we'll hopefully learn more in the later talks today. And so the idea that we're thinking of is that for NK cells, and for many immune cells in the sepsis, we are trying to fine-tune to balance their activation, so they still have the protective arm of the response, but at the same time we're limiting their contribution to the tissue damage and to the immunosuppression. And so with this, I think that's where actually the immunometabolism field as a whole can give us very interesting clues, because what we know from the immunometabolism way of thinking is that in order to sustain the prolonged and active activation of immune cells, they first need anyways to undergo what is called metabolic reprogramming, basically just shaping their cellular metabolism in order to provide energy and fuel for, let's say, the functional outcomes, right? And so that's our idea, and that's our hypothesis on what we want to achieve, is to control the functional response of immune cells, let's say NK cells in this case, in case of this project, by controlling their metabolism. So for NK cells, and obviously in the field, we know now for the recent few decades a lot about cellular metabolism of different immune cells, for NK cells as well. And for NK cells particularly, the most important or very nicely characterized part of their metabolism is related to amino acids. So, for example, NK cells really rely on SLC7A5 uptake for their function, and at the same time, they also require glutamine amino acid just for many other things. And glutamine is imported via SLC1A5, the only transporter that can import glutamine for NK cells. So in the lab, or like in this project, we have an idea and hypothesis that maybe targeting those two transporters will allow us to control the functional output of NK cells. So we are using a mouse model of sepsis. That's very similar to what was described by Sarah. So in this case, I will only have time to talk about the LPS inflammation model, but we also have the bacterial infection. So in this case, in mice, we observe quite dynamic response of NK cells to the inflammation. So they undergo actually two waves. So in the first wave, which we call early activation, which happens a few hours after the LPS, the main output of NK cells is interferon gamma production, and they are the main contributors to the overall interferon gamma production in this model. And later on, they shut down interferon gamma expression and instead turn up the perforin upregulation. So we're wondering what, let's say, metabolic requirements underlie this activation of different, let's say, parts of NK cell activation. And from the previous studies, we know that, as I said, SLC7A5 amino acid transporter is critical, and it's important for those two, say, master regulators of immune cell metabolism and immune cell activation, the mTORC1 and c-MYC, which are at the same time regulating the, let's say, the metabolic fluxes in the immune cells, and for NK cells, this results in interferon gamma production and granzyme B as well. So we're wondering, is the same mechanism applies for our model? So that's indeed the case, as we see the quite upregulated expression of CD98, which is basically a partner for SLC7A5 on NK cells, and also mTORC1 activation early after the sepsis challenge, so at the same time where interferon gamma is substantially produced. So of course, we're wondering, is there a functional link as well? So we can address that by using the knockout mice first, the mice where SLC7A5 can be knocked out only in, or like mainly in NK cells. And in these mice, we do indeed see a diminished interferon gamma response. So it's not completely abrogated, but it's substantially reduced, exactly what we want to have in this case. And in addition to the, say, genetic model, we can also use pharmacological inhibitor of 7A5, which is commercially available. And basically, we're showing the same effect. So just pharmacological inhibition of 7A5 as well suppresses interferon gamma production by NK cells. So it's obvious that this transporter, or these amino acids that are transported by this protein, are essential in fueling NK cell response. So the idea is that by modulating the activity of the transporter, the availability of those amino acids, we can fine-tune NK cells in one or other way. And it's interesting to know that, again, linking back to Sarah's talk on, let's say, the nutrient availability in the circulation, it's interesting that the organism, the body physiology, using the same probably mechanism. Like, for example, for the amino acids, we know that many of them are actually depleted in the, say, in the circulation during sepsis. This is, for example, our mouse data set. And very similar is observed in human patients with sepsis. So, and also I linked here the amino acids that are transported by 7A5. So they actually depleted during the early stage of sepsis. So this might be the one of the tolerance mechanisms that helps to, let's say, somehow limit interferon gamma response by NK cells. But that's certainly something that we are following up in this project. And going back to the, let's say, the late activation wave of NK cells, so we have an idea that probably in this case, actually glutamine and SLC1A5 transport are important, because we can measure glutamine uptake at or like, let's say, SLC1A5 mediated uptake in NK cells, and we do see that it is going up later, a few days after the LPS challenge. And at the same time where the perforin is upregulated, and also at the same time we do see an increase in respiration or the mitochondrial metabolism of NK cells. So we have a hypothesis that's probably glutamine that can actually feed OXPHOS and mitochondrial metabolism via Krebs cycle. By doing this, supports the production of perforin. And again, just to test if it's the functional link, we can inhibit SLC1A5 transporter with a pharmacological inhibitor, and we can confirm that SLC1A5 uptake is going down in NK cells. And it's interesting that it does not really affect in the interferon gamma production in this case, but rather the perforin upregulation is affected. So it seems that, just I guess to summarize this part of the work, or like the project so far, there are different parts of NK cell activation that are controlled, or that are, let's say, linked to different parts of their metabolism, and specifically in terms of amino acid metabolism. We found that 7A5 transporter is more linked to interferon gamma, and granzyme B didn't show that, and the perforin is upregulation is more linked to SLC1A5 uptake. So I guess that's everything for my talk. I would like to thank our lab and our group and our collaborators, and of course the really great collaboration we have with Marcella in the context of European Immunometabolism Network, a lot of insights in the field of immunometabolism, and of course Global Sepsis Alliance for co-organizing, for helping to make this session true. And yeah, I'm happy to answer any questions. Thank you.
Thank you so much, Maxim. We have first question within the chat. What happens to specific receptor SLC7A5 after the first LPS challenge? Is it internalized or blocked? Could this be one of the mechanisms for reduced interferon gamma after right challenge?
So we don't know actually what happens with the transporter itself. That's a big problem with within the metabolism field, is that for many of those proteins, we don't really have the suitable, or like, let's say, working antibodies, for example, for FACS. And obviously the population of NK cells is quite low, so it's really hard to get enough cells for the, let's say, Western blot or something like that. So that's why we kind of playing around and trying to use different approach to address how the transporter works. So one way of doing that is just by directly measuring the ability of the cells to mediate the transport. So there is the assay for 7A5, and it seems that I didn't show this data, but it seems that NK cells do upregulate the let's say the uptake capacity using 7A5. So I don't think it is internalized. I think it stays on the surface of the cells and just doing the job, but it's quite transient. So I suppose there are waves of expression, and what happens with the transporter, I actually don't know.
Yeah, thank you so much. We have another question. When we talk of metabolism, if it's possible to match the high negative nitrogen balance due to high catabolic state in sepsis, the maximum nitrogen that we can replace through the intravenous parenteral nutrition is 16. Can you comment on?
Is it possible to, like, let's say, to recover? Yeah, it's another big thing that I'm thinking about, is that, let's say, obviously the organisms have a lot of those amino acids inside, right? And let's say the amount of the amino acids in the circulation does not necessarily reflect the amount of amino acid metabolism in the organism, right? So it's actually known that despite having less amino acids in the blood, their production and clearance are quite high in the septic patients. So it seems that, maybe instead, by controlling either the production or the clearance of the amino acids, is even the better way of controlling, or let's say modulating their or restoring their availability in the circulation. But again, coming back to Sarah's talk, do we actually need to restore this negative balance? Or maybe this is the adaptive reaction that the organism did on purpose, right? Just to limit the pathogenic immune response, for example, pathogenic interferon gamma activation. So it's really a tricky question to answer, and I don't have the answer yet at the moment, but that's certainly what I would love to dig more.
Perfect. And we have last question from Sarah directly. So great thought. What is the consequence of loss of the transporter in NK cells with live bacterial model? Is there any effect on bacterial load?
Don't know yet. So that's actually ongoing experiment. So I don't have the results yet. But yeah, I would expect that maybe yeah, again, it depends on which cells will be the bacterial load. So probably I'm more looking into the, let's say, the perforin production of NK cells, because perforin was shown to directly target bacterial cells. So that would be super interesting to see if limiting perforin upregulation actually affects the bacterial loads. But that's certainly the ongoing part.
Thank you. And I'm just curious, do you see more, let's say, specific metabolic signatures based on your experience, or you can see all the data somehow uniformly?
You mean for the different immune cells, or?
Not different immune cells. I mean much more within the mouse model, since what I know from my expertise within the humans, there can be such a huge variability. So if you can see different, let's say, metabolic signatures within the NK cells.
Between different mice. Well, it's certainly like one of the advantages of using mouse models, right, is that the variability is way less than in human patients, and also as Sarah again pointed out, the causes of sepsis might be different in humans, while in the laboratory animals it's always the same, either molecule or the pathogen. Of course, if we're using different pathogens, like for example we are having the, let's say, the E. coli infection model and the Staph aureus infection model, the response is dramatically different. So between those two models, and this is very important to say, okay, this is a gram-positive or gram-negative pathogen, or yeah, like other factors like the virulence factors in the bacteria. So this all contributes and it all affects the functional response, and as of course it also affects the metabolism part of the thing. So that's certainly very important aspect to consider.
Thank you so much. So we will move to another speaker of this session, and it will be Marek Nalos. Marek is intensive care senior consultant in Plzeň in Czechia, but he is currently working also in Australia, in Canberra. And he is working there such a long time. So he moved there in 2002. And he also did some research fellow in Finland or in Germany. And now he's one of the member of the board of steering committee of the Center of Critical Care Research in Copenhagen in Denmark. And Marek is focused on critical care, echocardiography, lung ultrasound, and sepsis and immune function within this. Thank you. So stage is yours, Marek.
Thank you for the kind introduction and for inviting me to speak at this fantastic event. I've learned already so much, so thank you. And I'll talk about lactate metabolism in sepsis. I've been long interested in that. And as you said, I work both in Czech Republic, in Pilsen, and in Australia, moving between the countries every now and then. So what I was taught in medical school, which is a while ago, about lactate is that it is a dead end waste product of anaerobic glycolysis, that it is a cause of muscle fatigue when we run, and it's a factor in acidosis-induced tissue damage in shock, and often a cause of circulatory compromise. I was also taught that is a marker of poor prognosis, and I'll tell you that's probably the only thing that is actually true. So when we look at the lactate as a marker of prognosis, you can see that when the level rises from normal to very abnormal to more than 20 millimoles per liter, the mortality odds ratio increases by about 12 times. So that's a lot. And so there's association with mortality, and it is a warning sign. And if the lactate level is increased at 24 hours and doesn't improve in 48 hours, it is also associated not only with vasopressor requirements, that means the severity of shock, but also, again, with mortality. So the traditional explanation is that circulatory shock causes inadequate oxygen delivery and that it results in mitochondrial hypoxia. And that when mitochondrial oxidative phosphorylation fails, and the metabolism depends on anaerobic glycolysis, increasing lactate production, and that lactate diffuses into blood during cell hypoxia. And in sepsis, blood lactate concentrations varies in proportion to the ongoing deficit in tissue oxygenation, and the ability to reduce blood lactate concentration indicates restoration of oxygen delivery with resuscitation. Again, most of this is not true. So what is really happening? So the objectives of this talk is to tell you that lactate is a reasonably useful biomarker of sepsis severity, and it is a warning sign. But it's not a harmful substance, and it's not an acid product of anaerobic metabolism due to tissue hypoxia, although both of them may coexist. Instead, I will show you that lactate is part of normal intermediate metabolism, and that there is a shuttling of carbon and redox potential across cells and tissues and organs by means of so-called lactate shuttle. And that high lactate in sepsis is largely due to sympathetic overstimulation and also due to splanchnic vasoconstriction affecting lactate shuttle function. And in vital organs, lactate, in fact, is not produced by anaerobic glycolysis, but is in fact oxidized in vital organs by mitochondrial lactate oxidation complex. And I will not talk about the lactate as an important signaling molecule for immune function in sepsis, but there's certainly some evidence for that as well. So you all know about Coricycle, which was discovered in 1931 by Coris, husband and wife, who were of Italian descent, but working in Prague in Czech Republic. And you know that lactate moves from muscle to the liver, gets turned back into glucose in gluconeogenesis, and glucose goes into muscle again. But in fact, what happens in organs, in most organs, there's a free exchange of glucose and lactate, and on the molar level, they're about the same level. And you can see that they kind of mirror each other. So liver is mainly taking lactate and producing glucose. This is a study in pigs where they measured the organ flux between artery and vein of different organs. And you can see most other splanchnic organs, in fact, consume glucose and produce lactate, and kidney again consumes glucose and consumes lactate and produces glucose. And skin is the only organ which actually doesn't consume lactate. We also now have quite convincing evidence of so-called mitochondrial lactate complex, oxidation complex, where we have transporters that transport lactate molecule into mitochondria, and there's LDH and cytochrome oxidation complex that are able to actually shuttle lactate into the Krebs cycle in mitochondria. And because of that, we have this free exchange of lactate and glucose between different organs, and you can see that heart and brain readily take lactate, whereas liver and kidney take it and don't oxidize it, turn it mostly into glucose, whereas other organs oxidize it. So we have this lactate shuttle. Now, is it important in patients? Very much so. This is not sepsis patient. This is patients after traumatic brain injury. And you can see that although the blood lactate levels is almost identical, in fact, it's a little bit lower in trauma patients, there is a huge increase in systemic lactate production by stress. And the lactate is produced so that it supports glucose and lactate delivery to the injured brain. And so about half of energy actually initially comes from lactate to the brain. And this has been shown by the lab of George Brooks. So the lactate level we measure in blood, in fact, is not telling us that there's any lactate shuttle. It's not very obvious. We have to really look closely across different organs to be able to see the lactate shuttle. So just to become a bit more practical, where does the high lactate that we see in sepsis come from? It's perturbed lactate shuttling and it's increased lactate production. So let's talk a little bit about the shuttling first. You know that liver and kidney receive 20 and 25% of cardiac output normally. And we also know in shock and in septic shock, these perfusion to liver and kidneys is very much reduced. There's visceral vasoconstriction during stress. And therefore, the delivery of the lactate to the organs that turn it back into glucose is largely reduced, and therefore the level in the blood systemically increases. So the lactate shuttle is actually broken in sepsis. There's also increased lactate production, and this is mainly to the stimulation of the stress beta-2 adrenergic receptor. We know that adrenaline and noradrenaline levels are increased in sepsis, and we know that there's huge stimulation of glycolysis that supports the sodium-potassium ATP pump. And we know also from studies by French group, Bruno Levy, that if we block this sodium-potassium ATPase by obane, that lactate production is greatly reduced in human muscle, and that in fact the PO2 in the muscle in these patients is not low. So it doesn't have to do anything with oxygenation and anaerobic glycolysis. The second source of increased lactate production is the rapidly proliferating cells. And they're mainly leukocytes, lymphocytes, enterocytes, and fibroblasts, because they all upregulate glycolysis upon stimulation. This is known in cancer as the Weber effect, which has been long overlooked. And we can calculate that almost up to 50% of blood lactate production, the other half that doesn't come from adrenergic stress, may be coming actually from white cells. And this is just a paper showing how largely the glycolysis or glycolytic rate is upregulated in lymphocytes by Nicolak. And we looked at that on a transcription level and whole blood from septic patients, and we could demonstrate that glycolysis pathway was upregulated and the pyruvate to lactate turnover was upregulated, but so was the pentose phosphate pathway, which produces antioxidants and building block for nucleic acids and lipid membranes for rapidly dividing cells. And this is just some of the gene expression. You can see the pattern between control and critically ill patients. You can see they're almost totally opposite. So we have described this in a whole blood, not specific cells, the transcriptional reprogramming of metabolic pathways in critically ill, which support the formation of lactate. And just so if we have some time, just talk about the lactate associated with acidosis. Lactate is not causing acidosis. In fact, lactate, when it's produced by LDH from pyruvate, consumes proton, and lactate can or must be thought of as an intracellular proton buffer. And my co-worker, Professor Rob Roberts, who's doing this research in Czech Republic at the moment, has demonstrated in vitro that if you actually measure the pH of this reaction in vitro, you can see a steep increase in pH when lactate is produced in vitro. So in conclusion, increased lactate production, mainly in sepsis, is due to adrenergic stress, inflammation, sometimes due to cancer and medication. There's also coexistent a reduced splanchnic and renal blood flow that affects lactate shuttle, so the blood level rises. We have increased lactate level, and when this happens, it should be a warning sign for clinicians to actually see what's happening with these patients. Why are they in trouble? It's a warning sign, and we certainly should regard it as that. But we also have to say this is not due to anaerobic metabolism. In fact, the uptake and metabolism of lactate in liver and kidney, apart from the reduced delivery of lactate into these organs by reduced splanchnic flow, the actual uptake of delivered lactate and its metabolism is largely unchanged. And this has practical implications for treatment of septic patients, in that sometimes we're told we should guide fluid resuscitation by lactate clearance, and we should keep fluid resuscitating patients until the lactate normalizes. This is not always the truth. We should only correct the fluid losses the improved peripheral perfusion. We can be guided by capillary refill time and mottling on the skin. And we should reduce hypovolemia-induced adrenergic stress. But beyond that, if we target normal lactate clearance, we may actually over-resuscitate patients and potentially harm patients with use of inotropes and too much intravenous fluid. Thank you for your attention.
So thank you so much for really, really nice talk. And actually, I have a question. You mentioned the traumatic patients. And in traumatic patient, it's known that lactate levels are somehow oscillating. There is some, it's so-called window of opportunity when the traumatic patient can be operated or there can be done again the surgery. Do you see some kind of oscillating in the levels also within the septic patients, or it's just a steep curve when it's going up to the non-favorable, worst prognosis, or going down when it's good?
Yeah, well, sometimes we of course, we like to see that if the initial lactate level is high, we like it to come down. What it means is that, one, we have, probably targeted the source of sepsis successfully. And so we have less inflammation, less activation of leukocytes. And we also probably have restored some perfusion to the splanchnic area. So if the levels are high initially and they're coming down, it's a sign that they're doing something good. But we also have to be aware that pushing too much oxygen, pushing too much fluid is not going to help the lactate. It may dilute it, but it's certainly not going to affect. In fact, this may harm patients by causing too much fluid overload, which has been shown to be harmful. And we do sometimes see that the levels go up and down, and some patients do have beta stimulants like salbutamol. Some patients, are on metformin, and that affects the level of lactate as well. So we like to see it coming down, but we should definitely think about the various reasons for why lactate may be increased, and we should definitely not blame lactate for acidosis in our patients. The acidosis, in fact, is probably caused by something else.
Mm-hmm. Thank you so much. We have another question within the YouTube chat. So what do you think about the microcirculation damage during sepsis can increase lactate production or the opposite?
Okay, so that's a tricky question. So we know that some patients develop intravascular thrombosis and that we have huge heterogeneity in microcirculation during sepsis. And yes, the delivery of blood to cells is important, and as is the delivery of nutrients. So it will affect lactate production in some way, and the lactate production will be increased, as we've shown, by the adrenergic stimulation, and it will be increased by leukocytes and lymphocytes in the infected tissue. But to say that by targeting the microcirculation and improving blood flow in the microcirculation by itself is going to help us with lactate, I think that's a simplistic thinking. And again, the fluids should be given, the microcirculation should be treated so that we have corrected hypovolemia, we have corrected the adrenergic stress, and we have restored the perfusion to the splanchnic areas. And beyond that, I think the microcirculation will actually take care of itself if we have controlled the source of sepsis, either with antibiotics or surgery.
Thank you so much. So because I don't see any other questions within the YouTube chat, and I don't see now the chat from our own streaming platform. If can somebody see it there? Because when I'm sharing the screen, I'm not able. Anyway, currently, which is really a pleasure for us, currently there it's more than 100 participants on the YouTube. So thank you so much for attending this session.
Perfect, thanks. So we're moving forward, and great job, Marcella, taking hosting the half of the speakers. So now I'm taking your role and introducing other three, and you will be actually the next one. So it's a great pleasure for me to introduce Marcella. She's a principal investigator at the International Clinical Research Center in Czech Republic. So she's also early career immunologist and working in translational immunology field, and particularly biology of innate immune cells, their immunometabolic profile, and their possible role in septic shock and other immune disorders. So Marcella has co-founded the Beat Sepsis Consortium and also a member of the steering committees of the European Immunometabolism Network, and those two organizations are also organizing this event, and also the Czech Society for Analytical Cytometry. So Marcella, really looking forward to your talk, and you can go ahead.
Thank you so much. I don't have any single minute to recover. But I'm really pleasure to speak about the project, which is related to Beat Sepsis. And today I would like to speak about the sepsis-associated immunosuppression in the long-term immunometabolic defects. As it was mentioned, we would like to thank that we were able to do this kind of session together with Global Sepsis Alliance, with the European Immunometabolism Network, and with Beat Sepsis. And as it was presented by all my previous speakers, sepsis is still persisting challenge, and it's really and it's highly heterogeneous syndrome, which is induced and maintained by immune system. And who is at the high risk? It's newborns, it's younger children, and it's elderly. And what is really typical for sepsis, it's that first of all, there is a inflammatory storm, which is subsequently followed by immunosuppressive state. It's not perfectly divided. It seems that the immunosuppressive state, it's there whole time, but then it's even more massive. And what is known that this immunosuppressive phase can occur for such a long time after the initial sepsis once that it's over, and it's leading us to very dangerous and long-lasting post-sepsis complication, which so far do not have any specific management strategy. And what it's actually the immunosuppression in sepsis, and how does it look like? So there are many levels of the immune disturbance. As you can see on this picture, there is occurring the persistent inflammation, there is presented chronic catabolism, or there are some alteration within the cytokine production. On the other hand, there can be suppression of the adaptive immunity as a T cell anergy or even apoptosis. So what are the hallmarks of the immunosuppression? So as I mentioned, immune cells are somehow showing the hallmarks of exhaustion and impaired function, which is contributing to the persistent immunosuppression. For the monocytes, it represents some reduced phagocytosis or even problems within the presentation of the antigen, or there is an increased abundance of the myeloid-derived suppressor cells, which are actually contributing to suppressive state as well. In neutrophils, we can see the compromised migration and defects within the antimicrobial function. And as I mentioned, for example, for T cells, there is a present exhaustion and increased apoptosis. What is also known is there is presented dysregulated cytokine production. There is within the late phases, there is increased production of IL-10 and TGF-beta, which are contributing to the immunosuppression. And in later phases, there can low-grade inflammation occur. And of course, there is altered immunometabolism and mitochondrial dysfunction. What does it mean, the immunometabolism, and what are the alterations? First of all, metabolism, or especially immunometabolism, can be presented and as a source of energy and intermediate metabolites for various defensive processes, as you can see on the picture. And just to put it much more to the perspective, do you know how much ATP body consumes per day? it's actually 70 kilograms for 70 kilogram person. So it's basically the same way as we weigh, and it's 30 grams per 1 minute. And how much actually cause the immunity? Just 30% of basal metabolism is consumed by immune cells within steady state. But these numbers, it's even increasing when there is some kind of challenge, for example, some pathogen is coming. And to put it to much more to the perspective, one cytokine which need to be produced cost something about 2,300 ATP molecules. And all of these immunometabolic alterations are associated with the sickness behavior, where immune system is basically demanding much more energy. And there are several metabolites which can play its role as an extracellular adenosine. And how it's with the immunometabolism in sepsis. This balanced metabolism is one of the key features of sepsis, and the rate of the metabolism are increased up to 50%. And what it's known that increased catabolism in septic patient, it's persisting up to 2 years after sepsis onset, and it seems that it's much longer than 2 years. So we are not surprised that broad defect in energy metabolism is somehow underlying the immunosuppression or even the immunoparalysis in sepsis. So as I mentioned, the energetic demands, there are also some sepsis-borne mediators which are basically causing immunometabolic chaos in the patients. There are some cytokines, there are some pathogen-associated molecular patterns, or even dumps. And all of these molecules are somehow affecting immune cells and their metabolic profiles. There is also environment which is really full of some abundant metabolites, as Marek mentioned, the lactate, and not clearly linked with lactate acidosis. And basically, these events are impairing cellular functions and immunometabolism profile. And there are even more metabolites which are basically affecting immunometabolic state within the cells. So can immunometabolism serve to search and find some biomarkers? We believe that yes. So due to, or not just due to, but we establish Beat Sepsis Consortium, and we would like to connect the excellent immunology research with clinical outcomes in order to define some timely diagnosis of specific long-term consequences of sepsis and try to design some new prevention schemes for the patients. And immunometabolism, for sure, it's one of the cornerstones of Beat Sepsis project, which is also dealing with some area of interest as a clinical point of view, biological point of view. And then, as I mentioned, we would like to integrate the data and do some preventive packages. And how we are approaching this, BeatSep is currently enrolling 4 adult and 4 children cohorts and collecting hundreds of thousands of data points within the several time points from the admission to long-term recovery, and how it's with the immunometabolic profile of the sepsis. We are using really nice tool. It's Sanet. It's coming from Marseille, from laboratory of Rafael Arguello, and basically based on these tool, we can distinguish what are actually the energetic demands of the specific immune cells. So on this picture, you can see that monocytes are highly energetically, or they have high energetic demands. Neutrophil has much less. And for example, for NK cells or T cells, it's much lower metabolic activity. And how we can actually focus on the longer time points, as I mentioned, that we are much more focusing what is happening in the long-term phase or time. So we are focusing on on innate immune cells metabolism. And you can see that in time point 4, which is actually representing half year, at least a half year after the sepsis onset. For example, in neutrophils, you can see still big changes between the glycolytic capacity and mitochondrial dependence, which means that that neutrophils should be in, let's say, much more normal condition, dependent on the glycolysis. But then when it's when they are affected by the sepsis, there it's increased mitochondrial dependence, which can be even associated, for example, with less mature cells, and this is persisting very long time after the sepsis. As I'm speaking about the long-term time perspective, what it's about the sepsis survivors in numbers. We know that 20% of the sepsis survivors are rehospitalized within the 30 days, and another 30% of survivors are rehospitalized within 1 year, which is a really big unmet need for the current therapy. And what is also known that almost 75% of survivors is developing complex and systemic long-lasting disorders, which is termed persistent inflammation, immunosuppression, and catabolism syndrome, where actually beat sepsis is focused on. As I mentioned, in the levels of metabolism, there is increased and persistent catabolism of post-sepsis patients, and there is no management strategy. And actually, these are also data coming from BSEP, and this is a very nice cohort which we have. It's actually pediatric sepsis survivors, as Mariam mentioned at the beginning. There can be really affected by sepsis. There is every 2 from 5 septic patients are actually pediatric patients under 5-year-old. And what we see in these patients, that even after half year after the sepsis, there is more than 60% of the pediatric sepsis survivors who are somehow reporting the decline in health-related quality of life, which was assessed by the SF36. So now we know much more about these persisting long-term consequences, and we really need search for some management strategies for timely diagnosis and try to find adequate treatment before it gets exacerbated. So to sum it up, what are the current challenges and future perspectives? So what we really would like to, it's to understand the heterogeneity of the septic shock and its long-term consequences. And one way how to do it, it's targeting the immunometabolism, because it's possible approach how to distinguish the stage. And what is really important, immunometabolism and immunometabolic state, it's very sensitive for various modifications. And BSEP as a consortium will try to develop unique AI approach to integrate all these data in order to provide simple answers to the bedside. So at this point, I would like to thank all my collaborators. I would like to thank my mentor, Jan Fritsch. I would like also to thank all BSEP consortium and all our great collaborators, even from the EMNN. And thank you so much for your attention. And if you want, we would be really happy if you can follow us. Thank you so much.
Thank you very much, Marcella. It's really, really nice talk and introduction of the BSEP Alliance work that you have. So we're ready to have the questions. I think there is one question in the chat. So just again, encourage people that our great attendees, we have 100 people watching now live, which is really nice. So feel free to post your questions in the YouTube chat. So the question is, so post-sepsis syndrome is also seen in non-ICU treated patients. So how about supplementing micronutrients during the recovery? And there was also thank you about the great presentation.
Definitely, sepsis, it's not, let's say, these long-term defects are not affecting just the sepsis survivors, but it can be also even associated with the post-ICU. And at current stage, I cannot say if it be beneficial to really treat the patient with higher glucose. So maybe in the next time I can speak about it much more.
Looking forward to that. And another question from actually our speakers. So Marcella, great talk. What mechanisms are supporting long-term metabolism dysregulation in neutrophils and monocytes? Do you know that?
I would say that this is a quite hard question, because both of immune cells or both of innate immune cells are somehow fueling glucose, and for the neutrophils they are even also fueling their metabolism through the glycogen. But yeah, definitely you can play with it within the lab and have a look how different metabolites, even what how different metabolites will change their, let's say, metabolic stages. But what we see within our experiments, that actually even monocytes are dependent at the first stages on the fatty acid oxidation. Then they fully develop the glycolysis.
Mm-hmm. Do you think, like in general, that this really standing phenotype of neutrophils after the long actually after the sepsis? So do you think it's more a sign of the of, let's say, they're being more active, they're ready to fight, or it's somehow immunosuppression long lasting? Because obviously neutrophils are not that well known for mitochondrial metabolism. If at least Reinaldo won't say the opposite in his talk.
I would say that this seems that there is still present some remodelation of the bone marrow, and from bone marrow are coming much more immature cells. And neutrophils, which when they are much more immature, there should have some mitochondria. So it's realistic that they are really belonging to the mitochondrial metabolism.
Okay, that's great. Thanks a lot, Marcella. Great job. And I think we can move forward. So I don't see any other questions in the chat. So I will introduce our next speaker, which is Luís Ferreira Moita from Portugal. So he's head of the Disease Mechanisms Laboratory at School of Medicine, University of Lisbon. So he did his postdoc with Neerha Cohen in the US, and also the PhD in European Molecular Biology Laboratory in Heidelberg. And his central goals in his laboratory are to understand how stress responses modulate organismal homeostasis and how that knowledge can be harnessed for therapeutic applications. So Luís, really nice to have you here, and go with your talk.
Oh, thank you so much for the organizers for this wonderful opportunity to share our data. And to be in this setting. So the central goals of my laboratory are to understand how stress responses regulate homeostasis and how we can harness that knowledge for therapeutical applications. I won't define sepsis for this audience, but the purpose and the important point here is that we use sepsis as a model to study this homeostasis disruption, because it's a prime example where this happens to an extreme extent. I will also say that in spite of all these years, there have not been a substantial progression in how we specifically treat sepsis. And I would like to offer that in addition to what's currently done, we need at least a new pillar, which is the induction of disease tolerance in the line to what my colleague Sarah already mentioned. But I still would like to share for this audience that us and among several other groups around the world are proposing that organisms, in order to survive a severe infection, they actually require resistance mechanisms and also disease tolerance mechanisms. And this all only when we have both of these arms working properly that organisms can survive and preserve organ function. So in a way, these are two complementary disease defense strategies. One, resistance, which targets the pathogen for elimination, while disease tolerance does not target the pathogen, but deals with the consequences of an immune response and the tissue damage that is imposed by the pathogen itself. So we found now a number of mechanisms and interventions that actually protect in sepsis, at least in preclinical models, by inducing disease tolerance. And today, as we are talking mostly about metabolism, I'll focus on our recent discovery that tetracycline antibiotics are strongly protected in sepsis, in addition to their direct antimicrobial properties. So I won't go into details how we found this. This is actually published, so I can point you to the right link. Suffice to say that we found that treatment of preclinical models, in this case, E. coli injection into the peritoneum, mice could be dramatically protected by administration of tetracyclines. And this is not because of their direct antibiotic activity, because we engineer bacteria in such a way that they're actually resistant to tetracyclines. And so we still have about 80% increase in the protection when we treat the mice with doxycycline. Now, this is not, again, because we are targeting the pathogen, it's because these drugs are acting also on the host. As you can appreciate here, bacterial burdens either in the peripheral blood, liver, lung, or kidney that are key targets in sepsis do not have changes in their bacterial burden. So something else is going on, a fact that is also illustrated by a decrease in serological markers of organ lesion coming from different organs, which doxycycline substantially improves. This is also underscored if you look at the histopathology in these different organs. They are substantially better when we treat them with doxycycline, as you can appreciate here in the liver, the lung, and the kidney 24 hours after this model is initiated. Now, we wanted to understand why this was the case, so we did a number of things. We didn't see much changing at the transcriptional level, at least in the early time points after we initiated the infection. So we actually used on-target metabolomics to try and start to understand what was going on. And here we immediately saw two very critical signatures, one of them represented by different species in the endogenous corticoids, and the other one is a dramatic increase in lipid species that were circulating 8 hours after the infection. And we know that both of these signatures are relevant for what's going on, because if we inhibit the pathways that are associated specific with one or the other, we have dramatic decreases in survival. That is, for example, we can inhibit the glucocorticoid receptor, and we have a decrease in survival. We also can inhibit a pathway of uptaking lipids into the mitochondria with the etomoxir, which inhibits CPT1, and also we have a dramatic decrease in the survival against infection. So both of these signatures are important. So going one by one, we found that there is a dramatic accumulation of fatty acid, long-chain fatty acid changes. There is a downregulation of the machinery that imports this long-chain fatty acid for fatty acid oxidation, as was also mentioned here today, which is really very critical. And you can actually appreciate that the case by looking at levels of master regulators of this import, including PPAR alpha, and the targets that are downstream and orchestrate this import. Now, this is reflected by this accumulation, which we can see at the metabolic level, and we can see that we can improve those profiles. And this is really very important, and it's at the basis of this protection, because if we could administer doxycycline with now an inhibitor of CPT1, we no longer have protection with this drug. So this pathway is really important to explain why these drugs are protective. Now, the other signature, the increased in endogenous corticoids, is not substantially improved by administration of doxycycline. So we reason that perhaps the receptor, the glucocorticoid receptor, which is known to be inhibited in sepsis and is actually causative for the compensation of these patients, could actually be improved. And indeed, if we looked at markers of its activation, we can appreciate that within administration of these drugs, these signatures of the activity of this receptor are improved, as exemplified by the increases in the phosphorylation of the glucocorticoid receptor in serine 226 and serine 211, which we can then also validate genetically. Now, what is going on at the basic level? We know that the electron transport chain depends on a very precise orchestration of the stoichiometric balance between components that in the different complexes are either encoded by the mitochondria or in the nucleus. And we know that doxycycline inhibits protein synthesis in the mitochondria. So one hypothesis is that doxycycline is actually alter this balance. And this is something that you can see here, because if we treat with doxycycline and probe for components of the different complexes of DTC, which are either mitochondrial encoded or nuclear encoded, we can see that the ones that are mitochondrial encoded are strongly downregulated at the protein level, but those that are nuclear encoded are not affected. So our hypothesis is that by treating with doxycycline, we generate this imbalance, which is sent by the cell to orchestrate a compensatory response that resolves this problem, and that confers a cytoprotective response in sepsis in the different organs that are affected. So we can see that when we treat with doxycycline, we particularly affect the activity of complex 3 and complex 4. And so we ask the question whether this is only due to the perturbation of the activity of these two complexes, or regardless of which complex of the electron transport chain that was affected, that could be protective. So we looked into the role of fenformin, which is a strong inhibitor of complex 1, and we saw a very dramatic improve in survival. And interestingly enough, this happens if we give a single administration of fenformin to mice, but not if we do more than one administration consecutively, meaning that what really works is a transient, mild perturbation of these processes of the electron transport chain. And again, this is not because we are affecting the pathogen, but it is a strictly disease tolerance mechanism, as pathogen burden is not changed. So we can also appreciate here when we looked again by mass spec, and you see that the different species are substantially improved by administration of fenformin, as we've seen for tetracyclines. And looking into what might be going on, we found that a number of adrenergic receptors were strongly transcriptionally changed by the administration of fenformin or doxycycline. We saw both alpha and beta adrenergic type of adrenergic receptors, and in order to distinguish them, we actually co-administer fenformin in the presence of beta blocker or alpha blocker, and we saw that blocking alpha adrenergic receptors had no effect. The mice were still protected, but if we co-block beta adrenergic receptors with propranolol, we lost the protection. Therefore, beta-1 adrenergic receptors are required for this protective effect. And that translates into less accumulation of these lipids, as we can see here, measured by or red quantification or by mass spectrometry. We can also see that one example, sterol carnitine, is strongly downregulated by treatment with doxycycline, and even more prominently by fenformin. So in summary, we have demonstrated the ribosome-targeting antibiotics, here exemplified by tetracyclines, are protective in sepsis, and this is independently of their antibacterial activity. Electron transport chain inhibition induces disease tolerance in a microbiome-independent manner, data that I had no time to show you today. And disease tolerance can actually be induced genetical and pharmacological by mild and transient perturbations of the electron transport chain. And it seems that these effects are mediated or are due to the sensitization of glucocorticoid receptor in the liver, and also adrenergic sensitivity. Now, as a bigger picture, this fits into a broader conceptual framework, as we have demonstrated in the past and more recently that additional physiological perturbations, not only of protein synthesis in the mitochondria, but also DNA damage, and more recently, not yet published, but also replication stress and mitochondrial uncoupling can be highly, highly protective. So we reasoned that actually in order to start effective and protective immune responses, not only microorganisms need to be directly sensed, but physiological perturbations that are induced by these microorganisms are also sensed and are at least a second signal, which is required not only to induce pathogen elimination, but also to induce tissue damage control mechanisms that we call disease tolerance. So I would like to finish by thanking the people that actually did the work in the lab. I would like to acknowledge core facilities that were instrumental to achieve this work, and also the funding to do this this project that I showed you here today. And I'm now happy to take any questions you may have.
Great. Thank you very much, Lee. Really, really interesting talk. So we have a few questions actually from our chat, so maybe we'll start with them. So there is a question from Marek saying about metformin actually, which is also protective in sepsis when taken prior to septic events, like for example in diabetics patients. So do you think the effect on lipid metabolism is the, let's say, sole reason, or could there be other mechanisms involved into the role of metformin?
No, it's clearly not a single mechanism, even if it's an important one. In fact, we are still working on different mechanisms. This a bit of a glimpse. We are actually collaborating also with Maxim. We think that we found exciting insights into how these drugs might also be regulating other immune factors, which therefore decrease tissue damage, which is compromising organ function, and that does not necessarily rely only on modulating lipid metabolism, even if that's an important component. So in a way, this drug, in particular fenformin, is doing a number of things, is acting on multiple targets at multiple levels that all come together to give this spectacular protection that we see, at least in mouse models of infection. Having said that, we also did this for metformin, and we should say that, what I should say, that the protective effect is not remotely comparable. There may be some protection, but not that we can measure in these more aggressive models. Therefore, fenformin is really much stronger at protecting. And this might have to do with the fact that fenformin can actually go into every cell in every organ, while metformin actually requires transporters and is only acting at the level of the liver, at least mostly at the level of the liver.
Great. Another question about the doxycycline. So should we give doxycycline to all septic patients?
That's a good question. We thought about that. Of course, as I said, we like to understand what's going on in order to harness that knowledge for therapeutic application. And as we've done in the past, we're just finishing a clinical trial testing the role of DNA damage. We are just gearing up to test tetracyclines, in particular doxycycline, in a large clinical trial. So we are going to enter this recap map clinical trial and see what it's doing, if anything, to patients and how beneficial it can be. Now, doxycycline is not routinely given to patients, even if obviously antibiotics are first line treatments in sepsis, and they vary according to the pathogen that is at least suspected. But doxycycline is not routinely given, so there's an opportunity, and we'll certainly test it, not to control the pathogen itself, as I demonstrated here today, but as an adjuvant to start these tolerance mechanisms, which are critical to complement the resistance mechanisms.
Mm-hmm. There's also a question from the YouTube chat. So how does this affect neuroimmunological pathways?
Good question. Honest answer is that we don't know, and we hardly explore What I can say in connection to what I said today is, for example, it will sensitize the organism to respond to the catecholamines that are in circulation, and which the mice in this case are relatively insensitive in the setting of an infection. So touching mitochondria in this particular case, complex 1, but also complex 3 or 4 with the doxycycline, is in a way sensitizing to circulating catecholamines, that is the peripheral nervous system, to be more effective. So that we can speculate, we have not demonstrated or tested, but we are in the process of doing, that may help the organism to better control, for example, the blood pressure by being more sensitive to the catecholamines that are in circulation. So that's one possibility on how this may be affecting this neuroimmunological connection. Having said that, that may also be acting on all sorts of immune responsive cells, again by sensitizing to catecholamines. Of course, there's a possibility that this also be very relevant in the central nervous system, regulating different types of organ function. But to be honest, we have no idea what's going on. There's certainly something that we want to look at, but we don't have any concrete data.
Thanks, Louis. Looking forward for the updates in this direction as well. And yeah, I think there are no more questions. So yeah, we can move forward. And let me introduce our last but not least speaker for today, which is Reinaldo Salomão. So he's a full professor of infection diseases at Federal University of Sao Paulo in Brazil. So he's head of the sepsis research laboratory there. He's a former president of the Latin American Sepsis Institute, and he has quite a number of contributions in the field. And just to note one, he's an author organizer of the book Infection Diseases, Clinical Basis and Therapy. So we really welcome in Reinaldo, and you can go ahead with your presentation. I don't think we hear you, so yeah.
Oh, okay, right now. Okay, so first I would like to thank you very much, you, Marcella, Max, and Marvin, for the kind invitation. It's a great pleasure to be here with you. So I will focus more on the role of low-density neutrophils in infectious disease. In fact, we just came to this. Oh, I cannot move my okay. So in the last years, we have looked for peripheral blood mononuclear cells functions in sepsis. And it was clear for us that bacterial or microorganisms recognitions, monocytes functions, for instance, are modulated, and they present a downregulated function, as mentioned by Marcella, with antigen presentation, compromission, and as well as a blunting the pro-inflammatory cytokines. So what we did see that many people does not agree or do not see is that while these inhibitor functions exist, monocytes and neutrophils as well, they preserved important immune functions such as phagocytosis and as well as the production of reactive oxygen species. So it was not a surprise for us when looking at transcriptome and proteome leukocytes. In fact, in PBMC samples from patients with clinical sepsis, that in the wide range of dysregulated transcription, translation process, we could find a module of increased expression, gene expressions, and protein that were combined in a module that were facing the control of infection. They were antimicrobial properties. When we look at that closely, we could see that, in fact, in this model, we had genes and proteins typically related to neutrophils, like neutrophil elastase, neutrophil collagenase, and neutrophil granule proteins. So if we were looking at the PBMC proteomics, this would imply that, in fact, our PBMC were co-segregated with low-density neutrophils. So we came to this field of low-density neutrophils by this way. And in fact, looking back our PBMC preparations, you can see that in septic patients, there increased percentage of neutrophils among the leukocytes that were co-segregated. So for those ones not used to see the whole blood from human beings, when we take blood from a human donor and we centrifugate this blood through a gradient like FICO, for example, typically we have a granulocytes layer over the erythrocytes and a PBMC layer over the FICO. In disease states, and this means cancer or autoimmune and infections, we can see that co-segregated with PBMC, we will see low-density neutrophils that are cells that might be immature, but they might be also mature neutrophils, and they have an amazing regulation properties. They are pro-inflammatory, they can phagocytosis, they induce nets, but they also have some suppressor activities, like was clearly shown early in COVID-19 pandemic. Here, for instance, we can see that here are patients with different severity of disease in COVID-19, and you see that in moderate or severe disease, you have an increased proportion of neutrophils in the sample, and quite interesting, you see that these neutrophils will express this CD16 intermediate immunophenotype, and this is like in our sepsis patients, this will be correlated with moderate or severe disease. When we come back to our patients with COVID-19, and again with proteomic data, we could also see, among other results, when we see the protein-protein interaction in these PBMC samples, again, you see a really positive upregulated module, and again, related to neutrophil degranulation and antimicrobial humoral response. When we saw all those results, we moved on to look for low-density neutrophils expression or presence in different data, microarray data sets to better understand the role or the presence, the effect of these cells in different infectious disease states. So first, we took 13 data sets of infection, acute, chronic, viral, as well as bacterial infection. Here we had about 258 patients, 110 controls, and we could clearly see that, we could clearly see that using different strategies like reactome pathways to see the top pathways regulated in those samples, as well as multi-scale community network, global protein interaction, that pathways related to neutrophil degranulation or specific lumen was among these top regulated pathways. When we looked for those genes And we could see that there were about 49 genes that were common to these two pathways. And looking at the database, we could see, you see here at the right side here on the screen, that these in red showing upregulated genes, they were related to data set from acute infection, either virus or bacteria. And this is also clear here when you see the top 10 modulated genes, for example, neutrophil elastase. You see that the more changed expressions were in acute infections such Staphylococcus aureus, E. coli, and respiratory virus. So we were interested to see if these genes could be found also in data sets where we could have information about the outcomes of the patients. When we found 7 data sets in RNA-seq of infected patients where we could get information about outcomes, more severe, less severe, complicated, uncomplicated, and looking for in these data sets for the 49 genes that we had previously seen, we could find that 24 of them were more expressed in the severe form of the disease than in the less severe form of the disease. To make it a little close to really low-density neutrophils, we also look in the specific single-cell gene expression in LDN with CD16 intermediate expression that is more probably low-density neutrophils, and we compared the presence of these genes regarding to normal neutrophils or the CD16 high. We could also find that 25 of these 42 genes are present in this data set. Combining those two, we could find that 17 genes were here common to this pathway. So these 17 genes are closely related to the major neutrophils' biological functions. They have antimicrobial activity, peptides, enzymes, iron sequestration, immune regulation, and if we come back, they are present in acute infection. They are related to outcomes in this setting of acute infection, and they are enriched in CD16 intermediate neutrophils. Then we propose that those 17 genes might represent a low-density neutrophils signature. In a very preliminary data, we just look at our proteome data if we could see this, find these proteins in our PBMC data, and we could find that 10 of these genes, we could find the proteins, and the proteins were increased in septic patients compared to the healthy controls. Here, we could not make any correlation with outcomes. So, in conclusion, we do believe that our LDNs are increased in sepsis and severe COVID-19. Genes proteins related to LDN are upregulated in PBMC from sepsis and COVID-19. LDN gene signature is characterized in acute infections, emphasizes upregulated genes associated with disease severity and CD16 intermediated neutrophil population. So the LDN role in pathophysiology and as a biomarker for disease severity deserves further investigation. I would like to thank my collaborators in the lab, and especially these undergraduate medical students, and the João Vitor and Mateus, as well as postdoc Giuseppe Leite. Thank you very much. I would be happy to take questions.
Thank you very much, Reinaldo. Really interesting. And yeah, I guess we can have some questions. So those who are still with us from the audience, feel free to use the chat. And just meanwhile, can maybe start with some curiosity question. I know it's a very ongoing project, so you don't have much like information on the role, but I'm just wondering, like, since you found the iron, let's say, metabolism signature, right, in those neutrophils, and also I think sepsis is quite associated with anemia and well, low iron as well in the patient. So I'm just wondering, how do you think are those neutrophils contributing to the iron homeostasis in the patients, or is just more, yeah, the adaptation to the environment?
So thank you, Maxim. I think here, what is more close to our find is the iron sequestration as an antimicrobial model of activity. I don't believe, or I don't have any data or any clue to think that this iron sequestration would impact iron levels. But in the fight for iron that is needed for the bacterial survival and our cell survivals, I think that here this sequestration by these enzymes would be protective and also another mechanisms of bacterial killing.
Thanks. And also, do you see any, like, from your data sets, do you see any signature of, let's say, mitochondrial or more glycolytic metabolism? So that would really help Marcella with her work regarding those interesting phenotype.
So in fact, our previous data with either the transcriptome, proteome, and as well as cellular function. So mitochondria was among the really downregulated enzymes or gene expression in this previous data. What I can say is that we have a lot of evidence they are altered, but I cannot say as a marker for signature, for example, this role. In the case of this neutrophil-specific population, it was not one of the genes or proteins that were that survived all these steps for the gene signature.
Perfect. There's also actually a question from Marcella. So do you know how long these low density neutrophils persist in the altered levels after the sepsis?
No, I don't. I'm not sure. We have samples from D0 and D7 from patients, and we can see these neutrophils still 7 days after the beginning of sepsis or the follow-up of the patients, but I have no clue on the dynamics of these cells. One interesting aspect, Marcella, is that in fact, for decades, we used this data to recognize infection or even sepsis. You remember that the first sepsis definition said that we had to, it was SIRS at that time, okay? One of the signs was leukocytosis or the presence of immature neutrophils on circulation. In fact, these immature neutrophils in circulation are probably the low-density neutrophils that we are studying now. So it is a phenomenon that clinically we see this for decades, but perhaps there are some roles that we still do not investigate.
Great. And I think the last question from Sarah. So, do you envision targeting low-density neutrophils to improve sepsis outcomes? And if so, how?
So this is very recent data, Sarah. And again, as you and specifically Luís Moita also said, it's a little bit hard to segregate what is a host defense and we need to preserve, or what is in the host response is deleterious. I think we misunderstood this along all the sepsis research. But one of the things that is possible, it was clearly shown in COVID-19 patients, for example, that NETs were one of the neutrophil extracellular traps were related to the inflammatory response and related to organ dysfunction and the death. And NETs is an easy target pharmacologically to say. So I think NETs could be in a specific population a target for these patients.
Thank you, Reinaldo. And I think that's all questions that we have. So can actually move to our next part, although we are really approaching the expected, let's say, duration of the whole session. So I would really like first to thank all the speakers for exciting talks from really, really diverse perspectives. And yeah, as we have now on the screens, all 6 of us, so it's a really great job. And I guess we can move for a little bit of roundtable, so a little bit of the common discussion, although we won't hopefully last for too long. So first of all, for the audience, for those who are still with us, thanks for your questions and for your support as well. It's really important for us that you were engaging and you enjoyed the talk. So if any of you have any other questions to one of the speakers that were today, so feel free to write them in the chat, and I will try to pop them up. I think there was one question actually that appeared some time ago in the chat for Sarah, so I will probably start with that, and then we can move to maybe a little bit of discussion. So there was a question to Sarah, which is I think quite casual. So do you think we should leave glucose metabolism alone and allow the body to correct itself? Because it seems that different organisms have different pathways, and I might try to kind of move this question to, let's say, to any metabolites or to any pathways that we are discussing today. So should we leave them alone, or it's the therapeutic window there?
Yeah, so I think that's an excellent question. Obviously, it's quite too simple to say that. I think there's a few different things to consider. One thing I think that we need to learn more about is the different phases of metabolism across the spectrum of sepsis, right? Whether you're in the early phase or even in the late immunosuppressive phase, right? So I'm sure the metabolic profiles that are required to promote survival is required. I think the other area that requires a lot more study and research is understanding what fuels are preferential. And there may be differences across different organs. As we already discussed, there's differences amongst immune cells and different subpopulations of leukocytes, as well as understanding how different vital organs require different fuels. So I think the initial observation that we made, I think, is a starting point to, I think, one, understand the complexity, and two, a starting point to start doing all these different investigations, understanding the differences across different pathogens, and then also really trying to figure out at the different stages of sepsis, what is the fuel that promotes overall survival and tissue protection.
Perfect.
But,
Thanks,
yeah,
Sarah. If anyone wants to add anything to that question, yeah, Louis, feel free.
Yes, I wanted to absolutely agree with Sarah and perhaps expand a little bit on that. I think it's a common theme that we looked at many molecules and many pathways, and we find that some of them are upregulated or are overwhelming presence. And so the common assumption is that we need to intervene and block them or lower them. I think it's really very critical that we always distinguish on what's beneficial and what's counterproductive. And today we saw at least two very clear examples. One is glucose, which Sarah very elegantly explored, but also lactic acid is another example that we can now not safely assume that just because it's so high and is one of the best correlations with mortality and morbidity, that we need to get rid of it. And in fact, there's also already much data to suggest that it has a lot of protective and beneficial effects. So I think this is quite general. The other point that I wanted to make also and reflects our ignorance, and I think it's very critical going forward, is also the other point that Sarah was making on understanding what are the fuels, what is the metabolism programs as we move into the different stages in sepsis. But I wanted to add to that even there it's not straightforward, because we know also for a fact that there is overlap of different metabolic programs in different organs and perhaps at the same time. And so I think one of the things that is critically required is that we have ways of assessing spatially at different time points what's really going on, and try to target interventions to the different needs occurring simultaneously in the organism. And that perhaps explains why we have not been very successful at treating patients, or not dramatically improved on treating patients, because if we administer something systemically that is basically doing the same everywhere, that may not be good for all the organs or the cells at different places. So we need to have smart in the sense we need smart drugs or smart interventions that can assess what's going on and modulate in the best possible way to preserve especially organ function. And it's not very clear on how we can do that. For example, first of all, on how we can measure and assess, and how we can specifically and spatially intervene in the different organs. And by the way, measuring things in the peripheral blood is probably not very informative for what's really going on. So I think we need to work on all of those fronts.
Perfect. Thank you very much. Yeah, so I think we have some questions from the chat, so maybe we will actually deal with them, and that will be it for today. So Marcella, if you want to take over and
Yes, thank you so much. So one of the questions from the chat, it's do you think there is a link, and if yes, which link between organ damage during sepsis and immunity, and maybe complementation of the immunity in sepsis? Sorry for a complicated question. So do somebody want to comment on?
I mean, I guess I can start because that's really that I think it points out to what Sarah said before in the discussion as well. So like obviously the different organs will have, well, different metabolism, right, and different immune cell populations. And it's also very important to consider that in many times, especially if we're working with humans, we are, let's say, taking the PBMC, the cells from the blood, while obviously there are so many immune cells in the tissues, and in those tissues they have wide tissue specific features, and especially in terms of their metabolism, obviously the nutrient availability is very different there, and given the situations with the damaged organs, that's even more complicated. But yeah, I think it's very understudied it's quite hard to study, right, in the first place. So there certainly should be a link there, in my opinion. But and we're trying to look into that, for example, in the mouse model, where we're looking at the tissue resident immune cell populations in the various contexts. And it's like not what I was showing today, but in general, that's the direction in the lab. And we know that certainly in specific tissues, the same immune cell type, like for example, NK cells, they may have very different metabolic phenotypes, and they can respond to metabolic clues differently and to functional clues differently as well. So this is certainly something to consider. Anyone else want to add to that question?
Yeah, I can probably add to that you know, if you have inflammation, that's and I think recognizing more and more that a patient with sepsis, some of them are very inflamed and some of them are not inflamed at all. And we should probably approach them in a different way. And one of the markers that actually came out during COVID-19 was ferritin level. And some of the patients developed this macrophage activating syndrome or macrophage activating like syndrome with very high ferritin levels. And if you do measure it, you can probably distinguish those that are very inflamed, and that inflammation is quite damaging, probably similar to the macrophage activating syndrome with hemophagocytosis and things like that we see in hemato-oncology patients. So there will be effect in some patients on those organs, and maybe in some patients the effect will be more immune suppression, and therefore, you know, susceptibility to bacterial pathogens.
Perfect. So I think we had a really nice session. So I think we're approaching a little bit step forward in terms of our time constriction. So I think we can move on. And again, would like to thank all the speakers. It was really interesting talks and really interesting discussion. So, and I headed the floor back to Mariam for concluding words for this session. So thank you very much. And Mariam, you're free to talk.
Thank you, Maxim, Marcella, for the excellent co-chairing, and to Sarah, Marek, Luís, and Reinaldo for incredible presentation and the opportunity to share the latest knowledge. We all agree that complexity of metabolism and immune system response in septic patients remains a challenge despite the increased knowledge and efforts to understand the different pathways. And hence, as the Global Sepsis Alliance and the 6 regional sepsis alliances, including Latin American Sepsis Institute that Reinaldo was chairing until recently, we call and urge both member states and the public and private partnerships, including the foundations, to really allocate additional investments for research and development. As Luís mentioned, unfortunately, we didn't have any major breakthrough in clinical management of sepsis, despite the increasing quantity and quality of data and evidence. That is why the Global Sepsis Alliance just recently launched the Global Sepsis Innovations Platform that brings together researchers, innovators, sepsis patients, clinicians, and policymakers. Currently, we have 36 stakeholders, and the first inaugural meeting of the GSIP happened last week. So we invite all the co-organizers, BSEPT, the Trinity College, the European Clinical Research Center, and EIMN to consider joining the platform, because this is an opportunity to discuss the still unmet needs in prevention, diagnostics, and treatment, both antimicrobial, immunomodulatory, as well as post-sepsis care, and also to discuss some of the regulatory challenges that innovators and policymakers are facing in terms of increasing access to the novelties in terms of clinical management of sepsis. And of course, I would like to once again invite all our participants and attendees from the audience to the 5th World Sepsis Congress that will be happening on April 8 and 9. This session and the fantastic presentations that you shared will of course remain on the World Sepsis Congress YouTube channel, and we will ensure that it will be linked to the main agenda of the Congress. And last but not least, unfortunately, Professor Kisun, who was traveling today and was hoping to join us from the airport due to technical problems, he cannot be with us, but he conveys his best regards and gratitude for the excellent collaboration and convening this joint session today. Thank you once again.
Wow, what a session. I don't know if I can really add to these excellent words that Mariam just shared with us. Another huge thanks to all the speakers. A big shout out to Maxim and Marcella who co-organized this session. Thanks to Mariam and Tex as program chairs for the 5th World Sepsis Congress. And yeah, thanks to you. Thanks to being there on the stream. Thanks for your questions in the chat. We hope you learned something. We are super excited for the 5th World Sepsis Congress, which is just 6 weeks away. So take a look at the website, sign up, it's free. It's going to be online like this session was. We can't wait to have you there. Stay safe. Take care. All the best. Bye-bye.